Here we go. Okay, please, let's start.
It's 2045. No, I don't mean 2022. The APA, that is 45th. No, it doesn't matter. Good morning, everyone. If you could please take your seat. Thank you very much for coming to our APA Satellite Symposium. I'm Aida Habtezion, the current APA president, and I would like to thank my co-chair, Sohail Hussain from Stanford University, for this organizing the Satellite Symposium. And also I would like to acknowledge our committee who really had a lot of role and spent time to really structure this program. Dr. Eileen O'Reilly, Dr. Anirban Maitra, and also Dr. Yadav, Duraj Yadav here. I'll pass to my co-chair for some housekeeping and he'll take us a little bit and then we'll start. Thank you.
Thank you, Aida, Dr. Habtezion, and welcome everyone to this meeting. It's great to see a lot of familiar faces and new faces. I get to tell you about the housekeeping announcements, which is that we do have an exciting day. Everything will happen here for the meeting for today. There will be an attendee lunch, the Hirschberg Symposium afterwards, and the presidential reception later this evening. And for the reception and other parts, there will be instructions of exactly where it will be held. Please be sure to download the meeting app for access to the schedule, the abstracts, the speakers, to claim CME credits and more. And this meeting, along with all of the APA, will be recorded and available within the virtual platform for the next 3 months. And if you are a tweeter, we encourage you to please use this year's official hashtag, hashtag APA22. And if you don't know Twitter, don't worry about it. So without further ado, I hand it off to the moderators.
Thank you, Sohail. So we're going to get started. Our first session this morning is designing interventional clinical trials in pancreatic disease. We ask that the questions are held until all the panel have presented, and we'll ask them to come up here and answer questions so that we could keep time. Our first speaker is Dr. Duraj Yadav. He's a professor of medicine and associate chief of clinical research and academic development in the Division of Gastroenterology Hepatology at the University of Pittsburgh Medical Center. He's in active clinical practice with focus on pancreatic diseases. His research interests are in epidemiology of acute and chronic pancreatitis, and has published several key papers in epidemiology of pancreatitis, especially in its population distribution, the role of alcohol and tobacco in pancreatitis, and the natural history of the disease. He's funded by the NIH and DOD, and he's also the co-chair of NIDDK funded type 1 diabetes acute pancreatitis consortium, as well as the co-principal investigator of several ongoing multi-center studies, including longitudinal cohort chronic pancreatitis PROCEED, which is the EO1 for, it's called CPDPC in the NIH. Dr. Yadav has over 200 peer-reviewed publication abstract submissions. I can go on and on, but I will try to stop here. It's my pleasure to introduce Dr. Yadav.
Thank you so much, Aida, and wanted to thank the APA and the organizing committee for inviting me today to talk to you about defining endpoints for recurrent acute and chronic pancreatitis. I do not have any disclosures. I wanted to start by thanking Dana Anderson for his leadership role in the past several years in organizing workshops just preceding the Pancreas Fest. And two of these have been directed towards drug delivery or drug development and clinical trial development for acute and chronic pancreatitis. And I wanted to thank the NIDDK for organizing or sponsoring these workshops. This has been a wonderful platform to bring together all the stakeholders, including investigators, advocacy groups, and members of the FDA, so that we can all think through as to what the next steps are for our field in terms of developing clinical trials. The FDA also has guidance in terms of the steps that are needed for developing outcome measures, and this is a schematic that summarizes that information. The first step is to understand the disease or condition for which there is extensive literature in RAP and CP already. The second is to conceptualize treatment benefits. And here, there are two important components in terms of outcome measures. One is patient-reported outcome measure, and the second is either observer or the clinician-reported outcome measures. For patient-reported outcome measures, the FDA representatives made it very clear that these have to be measures that are reported by the patients without any interpretation, and they should help us to understand how the patient feels, functions, or survives. In terms of the next steps or developing the outcome measures by themselves, there have been a number of studies that have looked at individual components of outcomes of interest in pancreatitis, may it be abdominal pain, quality of life, or the specific components of the disease in terms of the natural course. What I think it is important for our field is to develop consensus measures that we can all agree upon that should be used both in observational studies to understand the sensitivity of change in the expected time frame that we are thinking about clinical trials, as well as the outcomes that should be used. In terms of patient perspective, Mission Cure conducted a survey of patients initially in 2018 and then updated in 2019. And according to the patients and parents, the most important symptoms that affect the quality of life of patients, not surprisingly, are abdominal pain, nausea, anorexia, and fatigue. And when they were asked in terms of what do you want the FDA to know about living with pancreatitis, lack of treatments, and burden of symptoms and their impact of life stood apart. In addition, patients also mentioned that there's a huge lack of understanding from medical professionals, specifically in terms of management of pain. The National Pancreas Foundation had a patient-focused drug development program 2 years ago in collaboration with Mission Cure, Rebecca's Vision, FCS Foundation, where again, in response to the question with regard to what are the top health concerns, the same concerns were pointed out: pain, fatigue, nausea, and poor quality of life. In terms of what are the specific daily activities that are impacted, social interaction and participation was pointed out to be the most important. Now, in terms of abdominal pain, these are the latest data that we published based on the longitudinal study PROCEED, where we looked at close to 500 patients with chronic pancreatitis in terms of self-reported pain experienced by patients. 86% of patients reported that they had abdominal pain at least at some point of time in the past year. 60% had severe pain, 25% had mild to moderate pain. Among patients with severe pain, 2/3 had constant pain, and among mild to moderate pain patients, 1/3 had constant pain. We looked at quality of life based on PROMIS questionnaires, Global Health, and PROMIS 29, and we found that severe and constant pain were the primary drivers for decrement in quality of life. We went further and used the T-scores based on individual responses of PROMIS 29 to determine what fraction of patients would qualify for clinically significant anxiety, depression, sleep disturbance, and low physical function. And patients with severe or constant pain had several-fold increased prevalence of these psychological and behavioral comorbidities. The reason I'm highlighting here this is that in addition to assessment for pain itself and the response to treatment for pain, there are other domains of interest that would be helpful for us to think through to incorporate in patient outcome measures and also to address them for overall improvement in symptoms with whatever treatments we are thinking about. This schematic shows the other aspects of RAP and CP in terms of clinical events that are occurring in this population. And clinicians in this room would attest to the fact that when we see these patients, which are represented here by a gray dot on the left, and the arrow is the longitudinal follow-up, and the different symbols are the clinical events that are occurring in this population. We see it on a regular basis that it's really difficult to predict as to which patients are going to have these events, how frequently these events are going to occur, and so on. So getting a better handle in terms of the expected events that occur in this population is going to be important as we think about outcomes. So as I mentioned, in terms of the PROs, a number of studies have looked at individual components of these, for example, pain, quality of life, psychological and behavioral comorbidities, and others. And in fact, there are disease-specific instruments that have been developed, for example, quality of life, the PANCOLI, the EORTC, and for pain, a recent development of compact SF questionnaire based on work by John Winsor and Aspon Drews. And this has also been validated recently. And there are also data, as I mentioned, on the clinical events occurring in a number of populations and what to expect. There are also measures like the Mannerheim criteria or Cambridge classification with its own limitations in terms of assessing disease progression, and the proposal of the COP score in terms of assessing the disease burden over the next 12 months in terms of hospitalizations. I think some of the limitations include that all domains may not be captured when we're looking at individual components, and there is also validity, and they need to be validated, and also the generalizability of these. And then, as I mentioned, the sensitivity of change over time is something that we need to keep in mind and understand, because that could have an influence in terms of sample size estimates. There are also similarities in terms of when we think about PROs and non-PROs, and heterogeneity in patient population is probably the most important, which actually separates it from, say, for example, if you're looking at just management of pain itself in different conditions. There are also so many other factors that determine heterogeneity in clinical outcomes in terms of age, gender, etiology, and so on. And as I mentioned, there are no consensus within the community in terms of what the common data elements should be. There are also differences between PROs and non-PROs. For example, if we are thinking about PROs, the prevalence of these and is greater as compared to when you look at individual clinical events, which would mean that you can have a shorter duration of follow-up or observation or therapy to understand the change that could be occurring relating to the medication or treatment. And this would have an impact on the sample size estimates. In terms of development, I think PROs could be developed by a consensus between experts with feedback from patients and other stakeholders. In terms of non-PROs, observational studies are going to be important, but here also a consensus could be helpful. So the FDA proposes two different models when we think about clinical trials. One model is where you have a physiological effect of any therapy as your primary outcome, say, for example, response of therapy to pain or clinical events. And then you can have PROs and a number of other secondary outcome measures. The other model would be is that you have a PRO as your primary outcome of interest, and then you can have different secondary outcomes. I'll give you an example of an effort that recently was published by the pediatric pain group. And this was a Delphi process through a consensus and one of the leads for this effort was Dr. Tanya Palermo, that many of you in the audience would know from the University of Washington. The reason for this exercise was that although for the past 10 to 12 years, the pediatric pain group has been using the pain impact guidelines for clinical trials, but the penetration of those guidelines for use have been only about 30 to 35%. So what the investigators felt is that if we can have a consensus among the community in terms of what we should use as domains, that could actually be helpful because it will not only synchronize efforts, but also it would allow comparison of results between studies. And they followed the OMERACT guidelines for this process, which is the outcome measures in rheumatoid arthritis clinical trials, which have been used for many years in the rheumatology field. This particular process took two steps. Step one was getting feedback from providers, patients, and parents to understand in an open question format in terms of what are the questions of interest and what are the domains of interest. And then there was a second step where they went back and ranked these domains in terms of their priority or importance and what questions should be included in these domains. And based on that, they came up with this model where you have a set of mandatory domains which should be used in all clinical trials. Then there are other domains that are important but optional depending upon what study you are doing and funding and other things. And then third is you can also include certain items purely for research. So I don't have any definitive answers in terms of what clinical or outcome measures to use. But as a field, we need to think about what are our goals for trials for RAP and CP. Among these patients, who are the patients that are of interest to study? And obviously, patients who have high burden of disease would be important. But how do you identify or classify or define these patients with high burden? Second is what are the disease manifestations that we need to focus on? Should it be symptoms? Should it be quality of life? Should it be clinical course of disease? What are the type of studies? And I believe initial studies would be pilot studies that we can learn from, refine the outcomes measurements, and then move on to definitive trials. And lastly, what is the intervention of interest? If it is a medication, what is the mechanistic basis for use of the medication, or what is the expected benefit that we are thinking that we are going to get? And then lastly, this is what I feel could be the next steps. We all need to come together as a field to develop a core outcome set. This core outcome set should be developed based on feedback from providers, patients, and parent perspectives. It should span across age groups, ideally as much as possible in adults and pediatric patients with some nuances that would be specific for different ages. It should span across disease spectrum. That means RAP and CP. These diseases are a continuum, so having different set of measures for RAP and CP would not be very helpful. As much as possible, they should span across the disease spectrum. And then, as I mentioned, the components that should be part of this core outcome set, certain mandatory items to include, optional, and those for research. They should be used in all observational studies, thinking through the time frame we are looking for a clinical trial. So for short-term clinical trial, 3 to 6 months of intervention, for example, pain, how does these measures change during the 3 to 6 months so that we can have an expected change that would occur? Similar to placebo response, this is also going to be very important for us to understand as to during natural course, how does pain change in patients? Second is to use them in all clinical trials going forward, maybe with some variations. And we need to start somewhere. And as we learn from the trials and the results, have empiric data, this would help us to refine these instruments going forward. That's what I have, and I'll be happy to answer any questions during the panel discussion. Thank you.
Good morning. My name is Eileen O'Reilly from Memorial Sloan Kettering. Pleasure to co-chair this session with Dr. Haviston. Thanks to Dr. Yadav for a great talk, and we'll certainly come back to that. So next, it's a real pleasure to introduce Dr. Diane Simeoni from NYU, who's a surgical scientist and a reputed investigator in the world of pancreas cancer. She has many accolades and will be an endless list here, but just to kind of enunciate a couple of highlights. She chairs the Pancreas Cancer Action Network Precision Promise Consortia in terms of the clinical trial, and that's going to be the main focus of the talk today. So thank you very much, Diane. We look forward to this.
Good morning. Great to be here in Orlando. I want to thank the committee for putting together this session, which obviously is an important one. I was asked to talk a little bit about an effort that we've launched to try to tackle an important problem, pancreatic cancer. And of course, we all know that despite all our pretty valiant efforts, we haven't really moved the needle sufficiently in pancreatic cancer. Here I just showed the data for the US. But really, we, over the course of my career, I think we've gone from 5 to 11% over quite a long period of time, which I don't find is making the kind of progress we need. And what we'd like to talk about is how can we develop a strategy to move faster and more effectively. So as a surgeon and a scientist, but wearing a hat as a surgeon, we're officially trained to try to resect patients, appropriately select operative patients, optimize therapeutic approaches to get negative margins, expand surgical boundaries if it can be of benefit to patients, and to identify and resect high-risk patients. But as we all know, there's still only a minority of patients that benefit from surgery. And even as we push the envelope to do more advanced cases, many of these patients are recurring. And this is actually a slide I made when I started off on faculty, is we have to actually develop more effective therapeutics. It's kind of akin to doing a liver transplant without having immunosuppression, right? We're really not going to be doing good for patients. We have to develop effective therapies to match our ability to surgery and detect the disease early. And actually, if we do these two things, as from a surgical approach, we'll be able to more effectively use the tools in our arsenal to help patients. Now, to the credit of many, including the NIH, PanCan, NPF, APA, and other organizations, we've actually grown the scientific community for pancreas cancer. And if you went to the AACR Pancreatic Cancer Conference we just had in September, it was about 700 or 800 people, which was pretty much unheard of in the field. And if you open any major journal, there's some compelling basic science paper that comes out. But as we all know, it takes a lot of work to get from a really important scientific finding to having something that we can deliver that's effective for patients. And so what we're going to propose here is a model to try to get us there. Increasingly, there are also more therapeutic agents at our disposal, but the question is, how do we actually partnering to get together? And as will be touched on at this meeting, there are lots of really interesting areas of therapeutic approach, many of listed here, all of which have potential to impact the disease, either individually or perhaps in combination. Of course, we have to figure out how to combine them, how to sequence them, and that's not a trivial task. And in fact, shown on this slide is to try to make the case that if we developed a platform that we could use to accelerate this and do this in a logical manner, it could be helpful to the field. Now, in the clinical trial space, and this is really from my experience, having some of my own work going to clinical trials and sitting on the NCI Pancreatic Cancer Clinical Trial Task Force, what you see are some of the issues in the clinical trial space. And there is going to be a session later on the Valley of Death that I think will touch on some of this. But it is hard for any individual or even any individual center to move compelling science forward into clinical trials. It's hard to get drug companies to work in this space. There's been a lot of casualties along the way, a lot of very large phase 3 clinical trials that have failed. I would say we have not done as well as we could as a field to share data. Probably the straw that broke the camel's back for me was a number of years ago when there were 8 different centers running a single arm phase 2 clinical trial to see if anti-PD-1 therapy worked in pancreatic cancer. All failed, no centers communicating with each other, no biomarker work. I know we can do better than that. We haven't done well in developing biomarkers for the disease, and I think there can be an opportunity here. And then only 4% of patients with pancreatic cancer go on clinical trial. And for those of you who take care of these patients, you know, it's tougher with this disease. There are more systemic manifestations. We have obstruction of the bile duct, GI tract, et cetera. So we have to, for a recalcitrant problem like this, we have to have a different way of working on it. So based on a conversation actually I had with Julie Fleshman sitting at the NCI Pancreatic Cancer Task Force after one of those meetings, I said, can we think about just taking a different strategy? And she was willing to go down that path. And it really started with a white sheet of paper and a year of a number of people working together, say, what should it look like? And I'll show you what's been developed so far, which I think is just the beginning of what we can accomplish. But with their support, now involvement of centers all around the country, and I'll show you the extent of involvement now, we have developed a new clinical trial ecosystem that can be leveraged not just for the centers involved, but for all of you that are interested in moving some of your work into the clinical trial space. So if you went through that exercise yourself, what would you do? It's kind of interesting to think about, but really the most important thing was we have to work differently together. We have to have a novel model of cooperation. We have to make sure that the clinical trials are vetted by strong, they are backed by strong science. They're vetted by strong scientific teams. We decided to go with an adaptive clinical trial design. I'll show you why. We have to learn from every patient. We haven't been doing that at all. I think we pushed the KPC model to the limit. I'm going to say this is the decade to study the human and find out what's going on as we treat each and every of our patients. Our patients deserve that. We have to share data. The nice thing about doing this with PanCan is there's flexibility. And then we had to develop a partnership with the pharmaceutical industry, which I'll show you what that looks like. And then to keep everybody honest, putting the patient at the center of every decision. And this did require, efforts like this require bringing key stakeholders to the table and making sure that you hear what everybody's needs are. And that was a very useful and effective exercise. We did decide to go with an adaptive platform trial for the following reasons. It allows us to test multiple therapies simultaneously as experimental arms. We have common controls. Just that simple single thing saves a lot of effort in minimizing the number of patients who get standard of care and maximizing the number of patients who get promising experimental therapies. I'll show you how we can actually, the trial is conducted so that if therapies on the trial don't perform as well as we think they should, that more patients are shifted into therapies that show promise. The trials are smaller than traditional designs. And we calculate that the time and money saved will be at least a third, if not a half, for a clinical trial. For those who are interested in learning a little bit more about this, I'll steer you to this review that a group of us wrote just to explain how these trials work, because they're coming on board, but they're still relatively new in concept. We talked about the fact that it did take some upfront effort, and this had to be, satisfying stakeholders. How are we going to share data? How are we going to make sure, for example, junior faculty at the institutions involved get academic credit? So for every arm, there's a junior faculty that is a co-PI of each arm. Basically making sure that we set it up that it was win-win as much as we could for everybody. We decided to start with metastatic disease, but I'll show you where we're heading. This is a trial that's designed for first and second line metastatic patients. The primary endpoint is overall survival, but surrogates can be built in as they're validated. I'll show you what the design looks like. We believe we can run to 5 to 6 experimental therapeutic arms at a time. Right now, I'll show you where we are. When talking to the FDA, they thought we had to run both standard of care regimens as control arms. So that's 30% of patients. Each of the 2 regimens get 15% over time. One of those may be picked as a winner, or with biomarker development, we may shepherd different patients towards Gem/Abraxane versus FOLFIRINOX. It's a phase 2/3 registration ready trial. The first part is no more than 100 patients. The second part which is if a therapy shows efficacy, is no more than 75 patients. And we use something called response adaptive randomization in the protocol. And one really important part we built in is we said to the statisticians, if a patient comes on the trial and the first therapy they get doesn't work, we want to be able to offer them something else. And I'll show you how we tackled that. So really, as the platform was originally developed, clinical trial concepts could be are vetted by an arm selection committee, which that can come forth from anybody. And then there's a phase 2/3 platform, paired biopsies before and on treatment at 8 weeks. And if something works, there can be a path for accelerated approval for the FDA. Actually, the FDA leadership worked with us. And if something doesn't work, we're going to learn quickly and move on and also learn why it didn't work. And then there's an underlay of supportive care research, interesting financial modeling, et cetera. Biomarkers are baked into this. You can come in with an arm with a hypothetical biomarker, which can be tested retrospectively. And then if it's shown to be predictive of therapeutic response, can then be seamlessly built in prospectively. This is all standardized across all the centers. The trial is a little bit complicated in the fact that you can come in and first line or second line as a patient, and drugs can come in either first line, second line, or both. And just to handle the standard of care part, if you get one of the standard of cares in the first arm, and you need to get another treatment, you won't get that standard of care in the second arm. So this is all baked into the statistics. This is just an example of what response adaptive randomization looks like. And just for simplicity, there's a single control. If you look at the top left, 3 arms all starting at the same time. And over time, you can see arm 1 is underperforming. And so as it underperforms, it's just going to gradually just fall off, and patients, that arm will get closed. But as arms perform better, patients will be shepherded into the better performing arms. A different way to look at it is here. So here you can see with the thin blue bars, the 2 controls, which will be 30%, and then the experimental arms, which are 70%, and we'll just use one arm as an example at the top. So an arm will come in, again, it starts at phase 2, and after 50 patients, there's statistical evaluation every month. And if the arm isn't performing well, then it will fall off. If it is performing well, then after 100 patients, and that's, there are certain statistical cutoffs, and the hazard ratio is about is a 65% likelihood that it'll be successful in stage 3. It will then seamlessly, without anyone knowing, go to the confirmatory phase 3, and then be eligible for FDA approval. This is just another way to look at it. This is a trial that goes on in time. So it's not standard and that doesn't have a defined endpoint. And over time, some arms will come in and they'll be found to work. And in fact, one of these arms may replace standard of care. Or as biomarkers are built in, then we may, as in other cancers, be separating patients early on to enter certain arms. Now, I just want to highlight, when you build something like this, it actually brings people to the table that didn't work on your disease, that have very interesting talents. And Don Berry's one of these people, and I won't go into all the details here based on time. But, we challenged him to develop the statistics so that we could give a patient a second shot on goal. And he said, well, we don't know how to do that. And I said, well, you're a creative person. See if you can figure it out. And actually he did. And it's actually based on wins above average used in baseball. So it's just an interesting lesson for all of us. We have fancier statistics in baseball than we have in doing clinical trials in patients. And perhaps we should think about who we have at the table working with us to solve these problems. But this is just one example of 12 new clinical trial innovations built into this trial, never built into clinical trials. And I like the idea of being able to innovate along the entire spectrum of what we do, from basic science discovery to even how we deliver care for patients in the clinic. It's all very important to our mission. We have a number of strategies to try to bring in arms. There is a pharma consortium that's been developed. We have now over 45 companies that are partaking in this. All the centers can bring forth science from their centers. Any of you that have a promising clinical trial concept can come forth. And we are now beginning to build in a phase 1 component. So for phase 1, any promising therapeutics out there, for example, you could look at the new RAS therapeutics that are coming in. We're trying to get some of those into phase 1 so then they can more seamlessly flow into the platform. I'll just show you this very quick example. Here's a basic science paper that came out in 2020. It was actually by Daphne Barsagi's group at Our Place. And there was some preclinical work published in January of 2020. Preclinical studies were looking at combining this with IL-1 beta, anti-PD-1 with gemabraxane. Discussions began with Novartis. And in the end, we went from the publication of that paper to this arm rolling into the platform in October of 2021. That's a timeline that has never existed before. And so it just highlights that this is a platform that the field can use to really drive a concept to clinical fruition. We have a number of arms into the trial. The one on the bottom actually didn't work, but importantly, only 50 patients were enrolled, and there will be a publication. All arms will be published, and all the biomarker work will be published with it, so we can show why the clinical trial concept did not work. We're adding in phase 1, hopefully locally advanced and resectable, supportive care. And this is a big effort, 30 sites around the country. And just in summary, this is a new clinical trial ecosystem, allows learning from every patient, and hopefully will accelerate the pace and scale at which we can execute change. Thank you.
Thank you, Diane. We're going to continue, I guess. We're going to continue. Can you hear me? You can, okay. We're going to continue to our next speaker, who's going to help us look into the future. Looking into the future clinical trials in pancreatitis is Professor Pramod Garg, who's coming all the way from All Institute, India Institute, Medical Sciences in New Delhi. He's a professor of gastroenterology and executive director, Translational Health and Translational Sciences Institute. He's very well regarded in the field with peer-reviewed journals, including very seminal publications and papers. His major areas of interest, including organ failure in acute pancreatitis, infected necrosis, and genetics, as well as inflammatory mechanisms of chronic pancreatitis. Thank you for joining us. The platform is yours.
Thank you very much for this kind introduction. Thank you, APA, for giving this opportunity to talk about clinical trials in pancreatitis. Can I have these slides, please?
Just a little technical difficulty. We'll get started.
So I'll have a few minutes extra. For sure.
Yes.
Yeah. I don't know why Dr. Saluja is, fond of organizing conferences, exotic places like Miami, Orlando, and Honolulu. People should be actually going out and enjoying, but here we are. And I'm very happy that more than, I think, 200 people sitting in the morning itself. So clinical trials in pancreatitis, of course, are very much required. I have no disclosures to make. The issues that I'm going to discuss include what do we need the trials for? I mean, there are many areas in acute and chronic pancreatitis that we must be looking at. What is the current status? Are there some trial design issues? For example, something that Dheeraj has touched in the morning, and what does the future hold for us? Now, acute pancreatitis is associated both local and systemic complications. Systemic inflammation is the one which leads to not moving, I think. Can the slides move, please? So systemic inflammation is the one which can lead to organ failure in patients with acute pancreatitis. And this is what defines severe acute pancreatitis. And that is the cause of most of the morbidity and mortality.
Can you help us move the slides, please?
Yeah.
Say that again. The flicker. The green one should be the one.
Maybe you can move it from there if you can. Yeah, okay. So can you go back? Yeah, okay. Go ahead. Next. So if you look at the mortality in acute pancreatitis, you can either say it is 1% or you can say it is 50%. It depends on what do you look for and what is it that you want to report as an investigator. So this is a series from Harvard, and I saw Professor Peter Banks here many years ago. This series was published of 1,100 patients. 9% had necrotizing pancreatitis, and mortality was 1.3%. Another series were published a few years later from UK. 759 patients, mortality was 42% due to persistent early organ failure. So this is an example of a patient, 62-year-old lady, came with abdominal pain diagnosed as acute pancreatitis, 30% necrosis. She had comorbid conditions. So age more than 60, comorbid conditions, but she recovers very soon and discharged on day 6. Mild acute pancreatitis. Fortunately, majority of patients fall in this category. And there is obviously no problem. On the other hand, you have a young man, no comorbid conditions, pain for a day, respiratory failure on day 2, renal failure on day 3, on a ventilator, dialyzed, and dies on day 10. And this is not uncommon in tertiary care hospitals, at least, where we have patients referred from different hospitals, and we realize organ failure is a major problem. Many years ago, we defined and characterized patients who have very early kind of fulminant pancreatitis. Those have, within the first 72 hours, developing grade 3 or 4 organ failure, and those developing slightly later. And we found that 11% of our patients accounted for 44% of all deaths within the first 8 days of hospitalization. And this was at a time when necrosis and infection were either absent or evolving. So, and now most people realize that early persistent organ failure is very important. And COVID-19, despite doing so much a disaster all across the world, has actually taught us many things when it comes to severe disease. And we find that less than 5% of patients with severe COVID had organ dysfunction. And possibly because of what is now being defined actually as a cytokine storm. So what is that? Sudden massive increase in cytokines, which lead to organ dysfunction. And something else which was commonly seen is steroids were effective in severe COVID, despite it being an infective disease. I mean, there are a lot of concerns about giving steroids to patients with sepsis. Although many trials were conducted, none of them showed improvement in mortality. But for COVID, severe COVID, viral disease, it showed benefit. And I'll come to this a little later. So what is the paradigm of an acute event leading to organ dysfunction? It be either infection, trauma, or pancreatitis. That's what we are discussing. It leads to local inflammation and tissue injury. With the release of PAMs or DAMs, there is pro-inflammatory response leading to systemic inflammation and organ failure. In some patients, there could be a second hit. For example, in patients with pancreatitis, we have infection. So you have pancreatic inflammation, tissue injury because of necrosis, which leads to the systemic inflammatory response syndrome. And that, if severe, can lead to primary organ failure. And in some patients who have necrotic collections, there could be a second hit of infection, what is called infected necrosis. And this may lead to late organ failure, what we call a secondary organ dysfunction. So this is what we studied in a prospective observation study of 614 patients. Mean age was 38 years. And let me put numbers here. 614 patients, 177 had primary organ failure, and 283 developed infected necrosis. Of them, 97 had secondary organ failure. Mind you, these numbers are from a tertiary care hospital where most patients are referred, so there is a definite referral bias here. And if you look at the outcomes, patients who had primary organ failure, 15% died within the first 2 weeks. Those who survived, 76% developed infected necrosis. And we found that primary organ failure itself is a predisposing factor for secondary infection, and this led to a mortality of 42%. Among those who had no primary organ failure but developed infected necrosis with organ failure, there was mortality of 36%. And those who had no organ failure but had infected necrosis, the mortality was very low, that is 4%. So comparing our data with other published series, there are three large series published. From our center, it was 42%. Data from Dutch pancreatitis group in patients with persistent organ failure, mortality was 38%, and one from Spain was 52%. So overall, if you look at the data among patients with organ failure, up to 40% of patients with early persistent organ failure may die despite whatever we do. So systemic inflammation is the critical element which requires target therapy if we are to decrease mortality. So we actually need clinical trials for organ failure. Trials for nutritional therapy, antibiotics, endoscopic techniques, etc., are important, but to my mind, not critical. So what is the current status? This is what we do in patients with severe acute pancreatitis. They have organ failure. They are admitted in ICU on life support. You call the intensivist, pray, and hope for the best. Do we have any treatment? Unfortunately, none when it comes to pharmacological treatment. In a Cochrane review in 2017, 7,366 patients were enrolled in 78 trials. And these trials, only 21 were funded by pharma companies. There was no difference in mortality with any of the treatment. With antibiotics, different antibiotics, prophylactic or therapeutic, nutritional, early or late type of fluid, there was no benefit. And the recent trial on whether we give aggressive fluids or not, done by a Spanish group, showed that if you give more fluids, there is worse outcome. So what we actually need to decrease mortality is specific target therapy for systemic inflammation. There have been some failed attempts in the past, lexipefan, probiotics, activated protein C, and also irinostatin. So what is it that the future holds for us? So we actually have to shift our attention from the pancreatic enzymes being activated in the SNR cells to cytokines. And we have to shift attention from SNR cell to inflammatory cells, because once the SNR cells are dead, they cause more and more inflammation. Although in the beginning itself, they do act as inflammatory cells themselves. So I looked at the trial registry of both clinicaltrials.gov and the WHO trial registry. There are 134 trials registered for pancreatitis. They're related to various aspects. For example, analgesics, nutritional support, fluids, endotherapy, post-ERC pancreatitis, and some on systemic inflammation. So some of the promising trials that are there, which holds promise in future, is one on TNF-alpha antagonist, infliximab, and Robert Sutton is in the audience, and he tells me that the trial has been started and around 30 patients have been enrolled. And this is in all comers, regardless of the severity of pancreatitis. There are two trials on steroids. One is in US. There's one trial in Germany on cytosorb, which is kind of extracorporeal removal of cytokines in patients with acute pancreatitis. And there is one recent trial on anti-IL-6 tocilizumab in patients with predicted severe acute pancreatitis. IL-6, to my mind, holds a great promise because IL-6 has been shown across multiple studies, including our own, that it correlates very well with the development of organ failure on day 3 of acute pancreatitis. And in fact, if you add IL-6 to SIRS, there is a very high positive predictive value and specificity to determine whether this patient is likely to develop organ failure or not. And there is supporting animal data also to say that IL-6 trans-signaling pathway is involved in the organ failure in acute pancreatitis. So definitely, I think anti-IL-6 therapy needs to be tested in humans. Coming to newer concepts, there is an ongoing trial on calcium channel inhibitor, and there are many in the audience who are involved with that study, and I think there's a lot of hope in that. There are 2 trials on low molecular weight heparin, because coagulation pathway has been shown to be involved not only in the development of necrosis, but also in organ dysfunction. And I don't know whether Vijay Singh is here. I'm looking forward to a trial on removing the unsaturated free fatty acids. And that is what he tells us that may be causing organ dysfunction. Are there certain trial issues in acute pancreatitis? I think there are some. I'll touch upon briefly on some. So timing of intervention, of course, should be as early as possible. And when you say timing, it should be taken from the onset of acute pancreatitis rather than from admission. So many of the trials will report that they randomize patients within 24 hours of admission. But to my mind, that's not correct. You have to see from what onset of pancreatitis or pain you have randomized the patient. The duration of intervention, to my mind, should be around 5 to 7 days. I found that some of the trials that I mentioned are giving intervention for 72 hours. The problem there could be that if you stop the intervention in 3 days' time, there could be resurgence of the systemic inflammation because there is ongoing injury in the pancreas and around the pancreas. With regard to the endpoints, I think the endpoint should be hard clinical endpoints. We shouldn't have soft endpoints. And the hard endpoints could be reduction in the search score and reduction in organ failure score. And of course, more importantly, mortality. Composite scores are often reported. The problem with that is, I mean, it leads to a somewhat lesser sample size, easy to do study, but I think they do not provide very robust answers for a robust clinical outcome. So ladies and gentlemen, I'd like to summarize by saying that mortality remains high in severe acute pancreatitis because of the early persistent organ failure. The current research is inadequate to tackle that. And if we have to decrease mortality, we need more clinical trials of targeted therapy against organ failure in these patients. Thank you for kind attention.
Sure. All right, thank you, Pramod. We're going to continue to our next session, how we might accelerate translational medicine through clinical trials. And it's a pleasure that we have Professor Peter Hegyi, who's also joining us all the way from Hungary. He's an internal medicine specialist, gastroenterologist, and clinical pharmacologist. He's a doctor at the Hungarian Academy of Sciences and deputy chair of the Clinical and Veterinary Science section of Academia Europaea. He's made seminal, again, important discoveries in the field of pancreatology, and we're going to hear more about it here, including some of the trials that are ongoing, exciting work that have been published in top journals, but we'll hear also with regards to clinical trials and how interventional clinical trials can be designed, and we can learn from you. Thank you, Peter, for joining us.
Thank you very much, Anna. It's really a great pleasure to speak here, and it's also nice meeting in person with so many friends. So I would like to highlight a little bit about how to translate scientific knowledge to community benefits. And we know the one-way methods, which actually starting from the basic science and finishing for the community benefits. But recently we have challenged this model. And the main reason is that this is only a one-way model, but how we go back to the laboratories, how we go back for new questions, and maybe not this is the model we should actually use. 3 years ago in the European Academy of Sciences, which is the largest organization in Europe in academic field, including 72 Nobel laureates as well, started to put together a new model, which is called the cycle model, to translate scientific knowledge back to patients' benefits. And after starting again the whole circus, because if you look at all research activities, one answer generates 5, 6 more questions, and this is the only way to go forward. So actually, of course, the best clinical trials based on a really good clinical strong background data about how to design it and what should be about the targets. So let's look at first of all one of our very first studies we have organized, and we started in a basic field. It's very well known in this field that pancreas secrete bicarbonate and huge amount of enzymes to the duodenum. However, how to be able to do that? Because they have lots of mitochondria and they secrete huge amount of ATP to provide the necessary energy for this process. And if we look at about what's happening if this project is damaged, either bile acids, fatty acids, alcohol, or other toxic factors causing a huge mitochondrial damage actually inside the pancreas, and actually this switch off all the functions of the pancreas. So one of the key cellular organelles is the mitochondria and the ATP depletion. So here is the model of the development of pancreatitis, in which you can see it's very visible that both in the ductal cells and acinar cells, there is a huge ATP depletion and mitochondrial injury. So how to go forward? And this is the next step. When we go until a clinical trial, the next step is about the applied science or preclinical field of the research, when how to tackle it. For example, especially Anna Bukovskaya, Robert Schatten, and Stephen Pandol and all other teams' work showed very elegantly that the mitochondrial permeability transition pore is a crucial factor actually in the initiation of pancreatitis. And if you try a different kind of moleculars, and we heard that there is also a study ongoing in Liverpool on this field by Robert Schatten, they actually showed that if you inhibit the mitochondrial membrane potential, this can be beneficial in experimental models. However, not only pharmacological interventions can be useful, but also one of the groups in Liverpool, David Criddle's team, put ATP directly back to the cells, and actually this saved the acinar cell damage. And in our work group, Victoria Venglovets also showed that if we give ATP back to the pancreatic ductal cells, the CFTR activity comes back and the bicarbonate transport come back. So replacing energy into the pancreatic cells, irrespectively they are ductal cells or acinar cells, are really beneficial. So let's move forward. Of course, you always need to summarize the current knowledge. What is the field? So we did a meta-analysis to look at what's happening in the very early phase. In the first 2 or 3 days, you put energy back with enteral feeding to the patients. And this study showed actually that both the amount of multi-organ failure and also the rate of mortality and intervention decreased in a severe form of acute pancreatitis. Not surprising that in the evidence-based guidelines, this is already in there. However, we also showed that might acute pancreatitis, the surrogate endpoints improving. And this is also a questionable whether always the mortality should be our endpoint or the surrogate endpoint could be as well. And here is the next part when the scientific circle can be really blocked. And this is the biggest roadblock in science between the basic field and actually the clinical field. Because here to do a clinical science, you need a really huge team. You need an interdisciplinary research support unit who help you to design the study and to run the study. However, you need a really translational pancreatic care with plenty of doctors who are interested in the study. It's totally different setup than being in a basic lab and working there and finding out new initiatives. So this was one of the main reasons actually why we established the Hungarian pancreatic study groups. And this was one of the main reasons why I changed universities recently. So if you look at the registers, the next time, of course, you always need to analyze the data you have, what you, in a best setup, you collected prospectively. And we showed that for those patients who started the enteral feeding on the 0 day, for the patients, the amount of severe pancreatitis and moderate pancreatitis decreased. and the patient's time in the moderate group in hospitals also decreased. So these are the real signs from the basic science to the registry analysis that if we give ATP energy back to the patient, this could be beneficial, of course, but there are huge amount of biases in science. So the final test also should be actually a randomized clinical trial. What is this session about? And this was the Guyard study we have initiated and started actually 5 years ago. And I must say that we are on the way to analyze the interim analysis. We are halfway about the patient's data, and we already started working on the statisticians. And this study has one arm which started with the 0 calorie on day 1, and the other, and after built up the energy back to the patients, and the other arm is immediately start with high level of energy. So this is like one example how a basic science work, understanding the basic physiology of pancreas can lead to a randomized clinical trial. But of course, not only this. For example, one of our other studies in the fatty acid part, it's already plenty of international brilliant centers did huge amount of research showing how fatty acids and alcohol damages the cells, both in ductal cells and acinar cells. And we also did a huge meta-analysis about the triglyceride level, which could be toxic actually for the cells. And it was very well shown that above 11 millimolar of triglyceride level inside the blood is really very harmful for the cells. After we did a huge data analysis of our prospectively collected registries, which also showed the level of around 11 millimole could be very dangerous and toxic, and elevating dose dependently this range of triglyceride level, dose dependently elevate the mortality and the severe pancreatitis. So we started another trial we called Elephant trial, eliminating the fatty acids. Actually, this is a randomized clinical trial with 3 arms. One of them is the plasmapheresis. The second is about the insulin glucose and heparin part. And the third one is actually a high volume resuscitation for the patients. So again, a basic science research led us to the clinical idea about how to remove fatty parts, how to remove triglyceride from the blood. But very importantly, not only randomized clinical trial can lead to change in practice. For example, one of our large trial understanding about the usage of antibiotics worldwide in acute pancreatitis, and in this study, 23 countries were there, it's clearly showed that generally there is a huge overuse, over 80% of the general usage of antibiotics worldwide. And when we saw it, what mislead the doctors actually to give antibiotics, it was very clear that misunderstanding the elevation of CRP level, misunderstanding the elevation of white blood cell count can lead us for a huge amount of antibiotics use. And if we use another guide, like the procalcitonin guide or the sepsis guide to start antibiotic treatment, we can dramatically reduce the antibiotic level inside the cell. So this is one of the reasons we had just the 10-year anniversary of the Hungarian study group this year. And for example, if I look at our activities, it's well visible that we try to use all the methodologies in the translational cycles from the very beginning, from basic science actually to the end. So currently the Hungarian pancreatic study group is running 9 clinical trials. We just finished one and published the easy one. There are 2 other studies which is in the writing phase. 2 other will be in the interim analysis phase. Another still in the enrollment phase. And we still have actually studies for preparation. And this is just our very first study which was published. We are really very proud. This is the very first artificial intelligence predicting program, the easy app, which can actually predict the severity of pancreatitis in the highest AUC. If we go further and we look at about the importance of this cycle, I must say that this is one of the most important part, that when you have the results, you always need to go back and ask the new question. So when you have the clinical trial in pancreatology, you also have to follow your patients and ask the new questions continuously. So for example, this is for another study, which is a continuation of our earlier study, because we also have to look what's happening with those patients who survive. 92 to 98% of patients survive. So is it really the mortality is the most important factor, or after we have to follow the patients who survived, and we have to look at about another endpoints, not only the mortality, but the quality of life, about the incidence rate of diabetes or chronic pancreatitis. For example, the APPLE-F is a follow-up of the pediatric group, the Guyash plus the follow-up of the enteral feeding group. The REUPEAR is to decrease the recurrence of acute pancreatitis in the alcoholic field, and the effort, which actually, again, how much fat can the patients get. And this is one of the analysis of the APPLE study, which clearly showed that most of the patients not reach the chronic pancreatitis or the diabetic phase, which means that we still have time. We still have time when we have the patients coming in recurrent children pancreatitis, how to interfere to decrease actually the amount of recurrent episodes or chronic pancreatitis or diabetes. If we go further to the Guyash study, it was really, really a little bit shocking data for us. If we look at the 2 years check of these patients, we could see that almost all patients who had pre-existing chronic pancreatitis had diabetes, but not this is the surprising data. The real surprise is that those patients who had no chronic pancreatitis before the AP episodes, after 2 years, around 50% of them has abnormal glucose tolerance, which is huge importance to develop really chronic diseases in these patients. Another issue is about how to design like our REUPEAR study. In this meeting, there will be also in the poster session about how to interfere for these patients. And we almost always think about pharmacological interventions, but for example, psychological interventions for these patients. And we show that if they are in the institution for the alcoholic and smoking patients, and we make intervention inside there, after 1 month, around 70–80% of the patients stop drinking. So this led us to design the REUPEAR study, which actually have intervention every 3 months for these patients with the psychological interventions. And the endpoint will be not mortality. The endpoint will be the event rate of recurrent acute episodes or chronic pancreatitis or diabetes. So one of my main messages I would like to highlight here, that the road to success in clinical trials is always under construction. So you always, when you have this kind of circle, you always have to think about what to change, how to go forward, what to check, and you have to go back to the laboratory. I was very pleased to see how many new models coming out, especially from Miklos Sahintót's lab concerning the new genetic models actually to developing this kind of chronic models. If you would like to design a good study, you need to understand about the disease development and the rate of basic and pharmacology part. So I would like to thank you very much for your attention, and like the earlier speakers, I am more than happy to join to the discussion part as well.
Thanks very much, Dr. Agay. That was great. So I'll now please introduce Dr. Peter Hussein. He's an associate professor at the University of Miami. He's a clinical researcher and medical oncologist and has expertise in immunotherapy and DNA damage repair. And he's going to talk to us about defining endpoints in pancreas cancer trials. Thanks, Peter.
Good morning, everyone. Thanks for coming out to the first session this morning and skipping the pool. I'm very appreciative of the APA and for the organizers for inviting me to give this talk today, and I feel humbled to be among these great presenters this morning. So my task is to talk about endpoints in clinical trials for pancreatic cancer. And I'm happy that my talk is after Dr. Simeone's talk, because she really set a very nice foundation for what I'm going to say. So I think while we're waiting for the slides to come up, we know that doing clinical research in pancreatic cancer is very challenging. This is a very difficult patient population. And Dr. Simeone highlighted some of the challenges that we have in terms of the low rate of accrual of patients onto clinical trials. And also, in addition to that low rate, we've also had a high rate of failure of late phase clinical trials. And I'm going to try to tackle that problem here. So in terms of I know what my slides say, so I'll try to explain it to you. In terms of defining an endpoint, first of all, we need to define what our goals of treatment are for patients with pancreatic cancer. So initially, we need to decide with a patient in front of us whether there's an opportunity to cure that patient. So especially in localized disease, we feel that there's an opportunity for cure with combined modality treatment with a combination of chemotherapy and surgery. And we know now that chemotherapy can improve the cure rate in addition to surgery. And there are multiple trials showing this. And the main endpoint that we use for those studies include disease-free survival and overall survival. Now, of course, the vast majority of patients with pancreas cancer, we cannot cure. And what we aim to do in that situation is try to extend survival. So many clinical trials in the metastatic space are powered to look at overall survival improvement. And hopefully I'll be able to show you that once my slides come up. And importantly, in parallel to trying to improve survival, we also aim to improve quality of life. And importantly, many patients who come in with, for example, I see a lot of patients with metastatic pancreas cancer. And a very common question that we get when we see a new patient is, does it really make sense to get treatment? Because a lot of people have this impression that chemotherapy will deteriorate their quality of life. And it's very important that we incorporate quality of life endpoints in our clinical trials, because what we know is that if we can control the disease, we usually see improvements in quality of life, even if we're giving a therapy that may be toxic. So for example, one of the main treatments that we use in pancreas cancer, one of the main treatments that we use in pancreas cancer is a combination called FOLFIRINOX. And FOLFIRINOX is a combination of 3 chemotherapy drugs. And you can imagine if you give 3 chemotherapy drugs to somebody who's older, may have some comorbidities, it's not easy to do that. But what we know is that if a patient has good control of their disease with FOLFIRINOX, we usually see improvement in quality of life despite giving a toxic treatment. Now,
Peter, I think what we can do is we put you in an awkward situation. I apologize. So what we could do is maybe the speakers come up here and answer questions. If you sit with us and then you could present, would that be okay?
Sure.
Let's do that.
All right. I'm
so everyone who presented, if you can come up, please. No, I think it's fine for you. Promote Peter, Diane. So we'll open up to just in the interest of time, please have a seat. And then we'll have Peter, we'll have you present at the end with your slides. Apologies again for the technical difficulties. So we'll open the floor. There should be enough seats. I'm not sure if we have the microphone on the floor. Yes, here we are. 1 second, Nicholas. We'll have the speakers sit down. Okay. All right, Nicholas, please go ahead. If you could introduce anybody who comes to. The slides now, so maybe we can do. Yeah. You want to go ahead? Oh, okay. All right. Sorry about this. So Dr. Hussain is going to pick it up, and then we'll reserve questions to after his talk with the panel.
Round two. Okay, so this is where I started off. So one of the primary goals, if we can, is to cure patients, and this really applies to patients with localized disease, and that's why we run adjuvant therapy studies. And then the aim, if we cannot cure patients, would be to try to extend survival, improve quality of life, or preserve quality of life. There's some trials that I'll point out that have been able to show maintenance of quality of life. And we want to advance science using a patient-centered approach. And we have now, for example, on the PanCan Precision Promise study, patient advocates who are involved in the decision-making process at the NCI Pancreas Task Force, the patient advocates, and all the cooperative groups to make sure that we have the patient perspective in the center of clinical trial design, to make sure that there are things that are innovative or interesting to patients for their participation. And advancing science also includes incorporating biomarkers into clinical trials, which is being done now more frequently and should really be a foundation of all clinical trials that we do now. And of course, the final objective in any clinical trial is to provide hope. And many patients come to us looking for studies because they feel that this is the best way that they have to try to overcome their disease. And many patients are kind of deflated if they don't have an opportunity for a clinical trial or if they don't qualify. So these are the relevant endpoints sort of categorized by stage of disease. So in the clinic, we think about pancreas cancer as localized versus metastatic. And in the localized groups, we have subcategories of resectable, borderline resectable, locally advanced unresectable. And in terms of changing the standard of care or changing clinical practice, the endpoints that are most relevant are overall survival or disease-free survival. Now, in earlier phase studies, for example, phase 1 and 2 studies, many times it's not feasible to wait for an overall survival endpoint to mature. And in those situations, we look for surrogate endpoints that could approximate overall survival. So for example, in some neoadjuvant studies, we incorporate things like resection rate or node positivity rate as surrogates for overall survival, and there's some validation for using those. Now, overall survival remains the gold standard, and this Kaplan-Meier curve is taken from the FOLFIRINOX paper that was published over 10 years ago now. And the curve on the right shows the FOLFIRINOX survival versus the curve on the left, which shows the gemcitabine survival, which was the control arm. And the median was improved, the hazard ratio was significantly improved, and the response rate was also improved. And this is what led to change in standard of care. Similarly, the second standard frontline regimen that we use, gemcitabine nab-paclitaxel, was approved in the US based on this clinical trial. The MPACT trial also improved overall survival and response rate in pancreas cancer. Now, in the FOLFIRINOX study, as I mentioned, they incorporated quality of life measures, and they validated quality of life scores that were conducted in this study and are in fact included in the Precision Promise study and many other phase 3 studies now. And what this study clearly showed is that even though FOLFIRINOX is a more toxic regimen, it led to an improvement or a delayed time to deterioration of quality of life. And this is very important. Even though we were giving a more toxic regimen, quality of life was improved because we achieved better control of the disease. So this is a small summary of pivotal trials that led to change in standard of care. The first one is the FOLFIRINOX study. The second one, gem nab-paclitaxel. The third one, nanoliposomal irinotecan, also improved overall survival. And quality of life was also included in that. And it showed that quality of life was preserved on that regimen, even though that's a relatively toxic regimen to give in a second-line setting. And then I'm not talking too much today about the POLO trial, which is a maintenance trial for patients with germline BRCA mutations after having received platinum treatment. That intervention was positive based on the primary endpoint of progression-free survival improvement compared to placebo. and quality of life was also preserved in that trial. And I think most of the clinical oncologists in the room feel that that is a clinically meaningful study, that we are happy that that was approved. Now, in trials of localized disease, I'm summarizing here some of the most important trials that have been done recently, both to change the standard of care and also to try to look for signals to move forward in phase 3 testing. So the first two trials were randomized phase 3 studies. The first one was a study using modified FOLFIRINOX in the adjuvant setting. So all these patients had resected pancreas cancer and were randomized to receive modified FOLFIRINOX or gemcitabine, and that led to a significant improvement in overall survival. The second one I'm going to show you in the next slide, the APAC trial, which hasn't been published yet, but has been presented 2 years ago. And that used disease-free survival by central assessment. In other words, an independent review of disease-free survival. And that study did not meet the endpoint, the primary endpoint of centrally assessed disease-free survival. Now, the modified FOLFIRINOX study looked at investigator assessment of disease-free survival, and there's a slight difference there. If I have a patient in front of me who had, let's say they finished adjuvant treatment 6 months ago, and they start losing weight, and the marker level starts going up a little bit, and they have some pain, and you have a subtle finding on the scan, none of those would be slam dunk reasons to say the patient has disease progression. But when you put all that together, it's likely, based on experience, that that patient is having a recurrence. If you have somebody else looking at that situation without the patient in front of them, they may not say, well, each of these things individually do not meet the criteria for disease progression. So that's a slight difference between investigator-assessed progression versus centrally assessed progression. And that may be the reason why the APAC trial didn't meet the primary endpoint. And that was the first time that centrally assessed disease-free survival was used to inform a randomized phase 3 study. The next two studies, the SWOG 1505 trial and the Alliance trial, were phase 2 studies and used different variations of survival as a primary endpoint. But importantly, the Alliance trial used R0 resection rate as a surrogate endpoint to decide in an interim analysis whether one of the arms of the study would continue or not. And I'll show you in a little while what happened to that study. But we had to try to figure out what was the best surrogate endpoint in that situation. And we're still not sure if R0 resection rate is the best one or not, but that does usually correlate with overall survival in localized disease. And then finally, the PREOPANC study was a positive study for overall survival. This is a study looking at pre-op chemoradiation versus standard surgery followed by chemotherapy. And that actually showed an improvement in overall survival on the most recent update. Now, this is what I was talking about in the APAC trial. So what I have on the left two Kaplan-Meier survival curves are the disease-free survival on the top left, and the bottom left is overall survival looking at modified FOLFIRINOX versus gemcitabine in the adjuvant study. And both of those were significantly positive. And again, as I mentioned, this is investigator-assessed progression. On the right side, you see on the top right, the APAC trial, centrally assessed disease-free survival. Those curves overlap, and I highlighted the hazard ratio and the p-value, which are non-significant. And even though the primary endpoint of disease-free survival was not significant, overall survival was actually improved. But that was not called a positive study because overall survival was not the primary endpoint of that study. And if I replace the curve on the top right, as I'm doing now, with investigator-assessed disease-free survival, that actually turns into a positive result, although that was not the primary endpoint of the study. Just to show you that these decisions are not easy. It's easy for us to now look in retrospect and say, maybe we could have designed that trial a little bit differently. But now we are waiting on the final results. Maybe if the overall survival curves continue to separate, this could become one standard in the adjuvant setting. And I mentioned already surrogate endpoints in neoadjuvant trials. So the panel on the left looks at the Alliance trial, which was a study of chemotherapy with or without stereotactic or hypofractionated radiation in the neoadjuvant setting. And on the radiation arm, that arm of the study actually was closed early because our zero resection rate in that study did not meet this pre-specified threshold to continue. Now, this study, small number of patients, so I don't think we can definitively say that radiation has no role, but this is a situation where the surrogate endpoint actually led to a significant change in the outcome of this clinical trial. And that's why it's important to really have validated surrogate endpoints when we're designing neoadjuvant trials. On the right panel, I'm showing you the SWOG 1505 trial, and they also reported, which is very important, our zero resection rate, lymph node positivity rate. There was no difference in the two arms there. This was a neoadjuvant study looking at gemcitabine nab-paclitaxel versus FOLFIRINOX, and this was supposed to pick the winner. And both treatments led to similar outcomes. So we couldn't really say if any of those surrogate endpoints were associated with survival, since there was no difference in survival at the end of the day. Now, I have to credit the group at Medical College of Wisconsin for this information on the slide. They are conducting a neoadjuvant study right now called a SOFT trial, looking at chemotherapy. This is in patients with resectable or borderline resectable pancreas cancer, doing chemotherapy first and randomizing patients to conventional chemoradiation versus stereotactic radiation. This is a 100-patient study with 50 patients in each arm. And they decided to use node positivity as the surrogate endpoint in this study. It would take a few years in their center, their median overall survival for patients with resectable or borderline resectable pancreas cancer is approaching 3 years and more. So they need a surrogate endpoint, and they use node positivity. And in fact, in their series and in other series, I referenced a paper from Dr. Ferroni that showed that node positivity after neoadjuvant therapy, or even in patients who have surgery first, is a good, robust predictor of overall survival. So I think this is something that we can use moving forward in our neoadjuvant studies. Now, I'm going to close just talking a little bit about the future. So this is a very important paper that was published about 5 years ago by PanCan. Lola Raheb, I'm not sure if Dr. Raheb is in the audience today, but they looked at the last 25 years of clinical research up to that point in pancreas cancer. Most of these were metastatic disease trials, and showed that many phase 3 trials were initiated without solid foundation in phase 1 or phase 2 testing. And what they looked at was what would be the appropriate threshold in an early phase trial to move to a phase 3 trial. And they showed that you really need to see a very significant improvement in progression-free survival, even almost a doubling of progression-free survival in a randomized phase 2 setting to justify moving to a phase 3 study based on this large meta-analysis. And what they showed is if that criteria had been applied, you probably would have avoided up to 11,000 patients being exposed to treatments that eventually failed in phase 3 testing. And I think this really provides a blueprint for how we should be, the bar that we should be using to move forward with phase 3 studies. And this is really incorporated in the Precision Promise design. And what I think we need to do as investigators is really have a sort of a critical talk with our pharmaceutical partners, because after this study was published, there was another 1 or 2 phase 3 studies that did not meet their primary endpoints, including a mitochondrial toxin called CPI-613, which was jumped into a phase 3 study based on a phase 1 study with 19 patients, no control arm. And then the phase 3 study ended up being negative, which, I think, based on what we saw now with the Precision Promise platform, we probably could have gotten that result with much less patient expenditure. So the way forward, I think, is something that has been alluded to already. This is my last slide. So this is a study by Dr. Linehan's group. And, this study is a small study, neoadjuvant, but the point that I wanted to make in these 3 studies that I'm talking about, and the last one actually was recently presented at the AACR Pancreas meeting, Dr. Simeone's group. All these studies are small studies, but the main thing here is that there are a lot of biomarker collection going on in parallel with treating patients. taking blood specimens, taking tumor specimens, and trying to find subgroups of patients that benefit. So we don't need to do a 1,000 patient phase 3 study. We might be able to do smaller trials in smaller populations to try to advance the science. And this is what the Precision Promise Consortium is aiming to do. So with that, I'll close, and I thank you very much for your attention, and I'll be happy to take any questions on the panel.
Thank you, Peter. So we're going to open the floor for questions. There are microphones on both the right and the left the room. Please introduce yourself before you ask the question. Thank you. Oops.
So maybe I'll kick us off here to the panel in the cancer world. So Peter, you kind of nicely elucidated many of the challenges in terms of endpoints. One of the things that we know is if we have a biomarker, that our chance of success is enriched, and how we can reconcile that with the fact that we have as yet sort of limited targeted opportunities in pancreas cancer. It's a big disconnect. I'd love to hear yours and Diane's and the panel's thoughts on that.
So I think this is a critical issue, and Peter highlighted, an important paper that was actually published by Lynn Matrisian et al., highlighting, how much, and all well-intended, but kind of wasted money and patient time and effort we've spent by not doing this the way we need to. And you have to start somewhere. And one of the big things we've tried to do with Precision Promise is really to convince the pharma industry to, instead of spending, hundreds of $millions in late stage phase 3 trials without strong science, is to invest in really understanding what's happening in the phase 1B space. And not, we really need to do away with single arm, phase 2 trials. So you have to walk before you can run. One of the things we all have to do is make sure every patient with pancreas cancer gets germline testing and their tumor sequenced, so we can at least understand, have knowledge in our pocket for every patient to begin this work. And then I really think the paired biopsies are critical. Even in that I-1 beta study, we talked about some of what were presumed to be the key biomarkers of treatment response in the mice were not what we saw in the patients with paired single-cell-seq biopsies and multiplex IHC. So we're all not as smart as we think we are, and we just have to kind of take all these assumptions we have away and actually see what the data shows us. And I would say that's a way to start. And I just want to make one other point about surrogates. Is for anything we want to say is a readout of a clinical trial, it all really has to be validated against overall survival. And the good part and the bad part is we can actually do that in pancreas cancer, because unfortunately our patients succumb to the disease early. But we can already see that if it's a R0 resection rate, that's probably not, unless you validate that, that's not going to be a good surrogate. And for Margaret's trial, she's, we've had conversations, she's kind of kicking herself that it should probably, OS is probably going to be the readout for that trial. And, just to kind of emphasize, we really have to be thoughtful about how we do this.
Thank you, Diane. Aaliyah?
Aaliyah Uch from University of Iowa Children's Hospital. So my question is for Dr. Simeone. So excellent talk for the Precision Promise trial. So, and the design about like having many studies to be vetted through the system, especially when, there's the problem with the numbers and just vetting the trials through the system. And I'm thinking about pancreatitis trial, especially for pediatric pancreatitis, where we have a limited number of patients eventually when we move through that space. So how did you decide a trial not performing well? And then you decided perhaps to sunset that trial and move on? And how did you decide a trial to be successful? I mean, how did you make that decision?
So first of all, it's decided a priori by a lot of, and this is with the adaptive platform, and the value of it is there's lots of modeling up front of what cutoff should be. And a lot of it actually has been validated using this approach in other large, similar but different, like I-SPY 2, et cetera. When I was hearing about Peter's effort and the pancreatitis, it actually made me think about efforts that are being done by Derek Angus at Pittsburgh, which I encourage you all to look at, because that might be a great paradigm. Actually, there it's an adaptive platform trial approach done in the real world setting. And I don't know if all the trials you presented, Peter, are all independent, large phase 3 where it's 300 control or 400 control, but you could actually have common controls and you could manipulate multiple variables. And he's done this for pneumonia very, very effectively, especially if there are treatments that are already being used in patients and they're not necessarily experimental, but it's just looking at just feeding early versus late work, or does giving antibiotics versus steroids work? You know, these kinds of things. I don't know if you're familiar with that approach, but it's worth considering.
Yeah, and one of the major difficulties of this that to finding support for that, because the pharmaceutical companies usually are interested in for new treatment options, and those are already in there. It's you have to do about in the same quality level like in the other studies, but how to find academic support for that? This is a huge challenge, I must say.
Thank you.
Thank you, Ida. Robert Sutton from Liverpool. Fantastic presentations. Thank you ever so much. I've learned a great deal. I would particularly commend Diraj's reference to the FDA, because we have to work with the regulators and we are constrained by their requirements. And clearly, if we have maximum pharmacological industry support and commitment to the area, they have to work to those requirements as well. And it does place limitations. For example, the Calcimedica's work, where they've recruited now some 70 patients for Oxora in acute pancreatitis, which is a fantastic effort, which James Buxbaum and Tim Gardner and Bechen Wu are making major contributions to. We have to work to those requirements, and Sudarshan Hepa's in the audience. So representing Calcimedica, are really grateful for their commitment to the area. I think that pancreas cancer is way ahead of pancreatitis, being able to put on a platform adaptive trial like Precision Promise, which is fantastic. We haven't yet got a pipeline in pancreatitis. We've got nothing in chronic pancreatitis. Acute pancreatitis we are struggling with. So in the United Kingdom, the rapid trial of infliximab was completely shut down during the pandemic for 2 years. We're now active again. Just some comments about some of the selection criteria and the outcome measures. The selection criteria are quite difficult, and they present real challenges in recruitment. So if you make the onset of pain the criteria for selecting the patients, and you say specify maximum 48 hours, you actually miss a lot of patients, because patients don't give good histories of pain. And they also complain of pain longer than that. And yet we've had patients coming in with 2 weeks of pain and an amylase of over 1,000. Now we know that the amylase has got a half-life of less than 24 hours. So we know that that acute pancreatitis has to have come on less than 2 weeks. So we missed that patient. That patient couldn't be recruited. And there again, we have to allow enough time for the medicine to be given. And that requires an infrastructure which you don't have, like in myocardial infarction or stroke. And so you have to allow at least 24 hours. We started off with 12 hours and we couldn't get the patients. So 24 hours at least in hospital. We're actually going to remove the criterion for restricting the length of time of the pain, because we're missing patients that way. There are pros and cons to all of this. It depends on who we're targeting. Are we targeting all pancreatitics, or are we targeting patients who've been defined by some criterion to try to address a more severe cohort? And that is partly dependent on the interaction with the regulators, partly interaction with the ethical companies, etc. When it comes to outcome measures, again, the pancreas cancer field is ahead because they have better defined outcome measures and in some ways more straightforward. But with acute pancreatitis, of course, the Dutch pancreatitis study group have advanced the composite measures, which they've used for more severe acute pancreatitis, particularly for necrosis trials. But if you incorporate more patients in acute pancreatitis for drug trials, then it becomes more difficult. And there are pros and cons. It depends on the phase of the trial. So if the early phase trial, we have to use a surrogate marker. So in RAPID-1, it's phase 2B, we're using CRP as a cumulative measure on days 2, 4, and 14. We've dropped days 7 and 28. It was too problematic. But there are other, we need a composite, basically. We need to work together to develop a composite, like they have in renal disease, for example. There's a lot to be done and a lot to be learned. And I think we just need to try and get more pharma involved. We've got very few pharma companies committed to pancreatitis. With that breakthrough with one drug, we'll attract them all in, hopefully. Anyway, thank you for all your contributions.
Thank you for the comment. Unless the panel wants, I can tell you that now that I have one foot, now that I understand how the pharma works, you highlighted a very important one. Pharma will not get in unless there is a regulatory path, a regulatory pathway. So this is very important. I think, Diane, what you actually presented is an example for us how to move that into the pancreatitis field. And Peter Hagee actually really like how you brought that model. And I'm wondering, in fact, could that be really a place to test so many of these, but you, as you highlighted some of the challenges, and Duraj and Pramod, if you can say also something about the endpoints, the difficulty of the clarity, what endpoints should we use for acute pancreatitis and chronic pancreatitis, regardless of what asset or what pathway we're going to test, when we have a very beautiful platform from Diane, and we have this beautiful setup that you have invested a lot, Peter. So I feel like there is a light at the end of the tunnel. Maybe this is at the end of the discussion in fact, the symposium, today's symposium is supposed to take us to the next step with these. So if you have a quick thing that you want to respond to Professor Sutton's comments, and then we'll go to questions.
I think Robert said really, really highly important questions, and we must find the good endpoints. And this is, as I referred also in my talk, I'm not sure that this is like the mortality, which we need to come back a little bit to see the others. And for example, I just also have a question to Duraj about the endpoints, because we are sometimes looking at the static endpoints, whether the have a recurrent episode, no, whether there is an intervention, and no. And why don't we think about the dynamic of changes? Because, for example, in your talk, it was very visible, and also in the acute pancreatitis talks as well, that this is a very heterogeneous disease. Some patients die on day number 1. Some patients, as you said, Pramod, die, on the 14 days or whatever. It's in chronic pancreatitis. Maybe endpoints which not measuring a static value, but a changes from one to the others, maybe would show the which way we should go forward concerning the intervention.
Well, I can tell about RAP and CP. I think there are a lot of challenges, and Robert very nicely outlined them. The challenges are both upfront in terms of who to treat, how to design an appropriate trial for that, and then what to measure as an endpoint. But the way I would say is we need to start somewhere. And I think the way to start would be is to have some sort of a consensus as to what outcomes we need to measure. We are not going to be perfect. If we are going to look for a perfect solution, I think that's not going to happen. There are so many things that we need to answer, and this has to be an incremental effort, coming up with certain set of criteria that we are going to use an endpoint. We'll do the studies, we learn from that, and we refine it going forward. I think that's the way to go. We are not going to be perfect at the beginning.
So thank you, Robert, for your comments. So with regard to the timing of intervention, I agree with you that you can only randomize a patient once he reaches you. So I agree that instead of 12 hours, you can have 24 hours for logistic reasons, which is fine. But the point I was making is that if you have to report from onset of pain to timing of intervention, because someone could come in within 24 to 48 hours and someone will come to your hospital after 2 weeks, and both are absolutely different patients. So I think when you have a set of inclusion criteria, we have to make sure that there is no major heterogeneity with regard to from onset to the interval from onset to intervention. That's one. Second is with regard to endpoints, again, it depends on your trial design. If you're looking at organ failure, I think the organ failure score or SIR score is an important endpoint. If someone says decrease in IL-6 or decrease in CRP, that is surrogate marker. Whether or not it will translate into clinical benefit is a big question. So when I said we have to have hard clinical endpoints, this is what I meant. If your infliximab is going to work in severe or predicted severe pancreatitis, you have to show that there was a reduction in organ failure and mortality. If you're talking about mild pancreatitis, you have to see the hospitalization duration was reduced. So that's what I meant. Thank you.
Go ahead, Diane.
So we spent a lot of time to build this so it could be, every other group didn't have to go through what we did and can learn from it. And since we built this out, now there's been something that's been used in prostate cancer, COVID clinical trials, et cetera. But what I would encourage the pancreatitis field to do is not to put all of pancreatitis in one bucket and figure out how to do this. Figure out what is the patient population that is you need to start with to make a difference in the field. And it may be the really sick patients, and you'll have to define what they are, and then you're going to need to define what your readouts are, get regulatory agencies involved early, include pharma companies, and as a group, set this together, because you're talking about mild patients, severe patients. It's not going to work if you bucket them all together. Just some suggestions to think about. Having gone through this, because I'm telling you what we went through wasn't easy, and we spent a whole year where we had a subgroup of folks involved said we just want to build out an IIT platform, but I didn't think that was going to get us where we needed to go, because okay, you do an IIT and maybe there's a signal or there's not, but then where do you go from there? So that's why we built a registration ready platform, and now that it's built, the other pieces can be added. So you really have to think about what does it need to look like to ultimately get you where you need to go. If you noticed, even though, you know, I'm a surgeon, we didn't start with resectable disease. We hope to get there or locally advanced, but you may want to start with your severe patients and say, okay, this is the patient population we really need to make a dent in. And what is this platform going to look like? And that might be a place to start.
Thank you, Diane. That is a very good point. The ones that are likely to progress to severe disease is a very good option. Question.
All right. Yeah, I'm Jeff Way. I'm from Harvard Medical School, and I actually am a drug developer. And so with regard to the pancreatitis trials and so forth that are going on with regard to organ failure resulting from acute pancreatitis, are there animal models that represent the type of organ failure you're looking at? And are some of the molecules you talked about, like the anti-TNF and anti-IL-6, are those effective in the animal models?
That would be Peter and Prahad.
So I think this is a very, very important question, because once you talk about drug development, we actually need very good models. Unfortunately, so far, people have been using surrogate markers for organ dysfunction in the animal models. And the most commonly used animal models has been either a mice or sometimes rat. The problem is that when you talk about humans, when I say organ dysfunction, I'm looking at oxygen saturation, I'm looking at fall in blood pressure, I'm looking at rise in creatinine and other things. When we talk about animal models, we only look at neutrophilic infiltration or MPO activity in the lungs. That's not good enough marker. And same way, it is very difficult to measure their blood pressure and pH and other things. So recently, for example, what we did, we had a rat model, which is about larger animal, and we actually inserted a cannula into the carotid artery and measured the blood pressure in real time, oxygen saturation, pH, and other markers to reflect if they are developing organ dysfunction in acute pancreatitis. So unfortunately, we can't have a bigger animals like a monkey or non-human primates, which would be ideal, but because of regulatory issues. Thank you. That's a very important question.
A very important point. We must admit we don't have a good model for acute pancreatitis, that's for sure, because the organ failure. We can measure the local failure and also the mortality. However, if we look at the mortality, most of the patients die in sepsis. And I was very pleased to see Hannah Algu's earlier study on PECs, and he developed a very good sepsis model. I don't know what's happened after that. I will ask him once, because after it stopped. But we need definitely new models for acute pancreatitis, because this model is good to test a hypothesis, but not good to test or predict whether this will work in human or not.
Thank you.
Sorry to cut in. So I just have a continuous question for the pancreatitis mice model. I'm from University of Nebraska Medical School, Medical Center. I'm still PhD candidate, so I'm probably asking a little bit more technical, but less complicated question. So the thing we talk about the pancreatitis and its association with necropsis. I just have a quick check. Our clinical standard might be we measure the blood IL-6 level. I think there's a standard a trend 8.9 pg per ml, something like that. Then for me, I have a KPC-based other gene knockout model. They need to have a pretty early mice death, which we can receive 17 to 19 weeks. But I mean, my boss think maybe it's because of a cytokine storm which causing this mice death. Then we try to measure IL-6 with ELISA, but we didn't see that. So my question would be, in the KPC model or the chronic pancreatitis or acute pancreatitis models, do we measure IL-6 as a marker for that? Then if we measure that, how we, what's a normal number for that? Or it's really depend on different model. For example, the the chronic pancreatitis might have a different number compared with KPC mice model for PDAC model.
So, sorry, I guess you're asking sort of from animal models in chronic pancreatitis, what would be?
Dr. Gag or, yeah.
I'm sorry, I'm not sure about the question.
So the question is in mice model or different, compare chronic pancreatitis mice models and KPC PDAC models. Do we measure IL-6 as a marker for chronic pancreatitis or cytokine storm?
Do we measure?
Following that, if we doing that kind of measurement, what's the number for that?
I'm sorry.
So I think the question, if I understand it, but there will be a specific actually session that will look into the animal models, looking at in terms of endpoints, et cetera. From an experimental perspective, there are a lot of abstracts, so probably I would refer you to that. I think the question was the IL-6 that you presented, perhaps in terms of markers that we could use for chronic pancreatitis model, similar to PDAC, I think was the question. If you have a quick answer, otherwise we'll refer to the others.
IL-6 has been measured in different animal models as a marker for severity, particularly systemic inflammation. So, and I showed you one paper where they have shown that transsignaling IL-6 transsignaling pathway is important for organ failure in the animal models. So that's why, and they could show that if you antagonize that, then antagonist will actually lead to better survival.
So basically, if we measure when we dissect the mice, we collect the serum. If the serum didn't give any higher amount of IL-6, that means it didn't have pancreatitis.
Right.
Thank you for the question. I guess we're going to move, Minoti.
Thanks, Aida. Thank you for the wonderful presentation from the panel. My name is Minoti Apte from Sydney. I had a question for Pramod, and it circles back to what Peter said about coming back to research from your clinical trials. So Pramod, you said that the infected necrosis was what predicted, or at least was what made patients have a poor outcome, right? A naive question is, where do you think the infection comes from? And does the microbiome have a role to play? And would that be a research question that needs to be asked?
Thank you, Minoti. Great question. So most people believe that it could be transmigration from the gut as a source of infection, although there are not very robust evidence to that effect. But what people have shown both in experimental as well as human studies that there is increase in gut permeability, there is endotoxemia, and likely a source is that. In many patients, actually, we see that there is a fistulization between the gut and the necrotic collections. There we are sure that the infection has come from there. But studying the gut microbiota and showing actually the same organism there is something that people are working on, including our group. Thanks.
It was a very, very important point, this kind of microbiome. But and I think here about the pathomechanism is also multiple hits. So what we can see, for example, that the biggest question about the pancreatic inflammation, yes or no? Because if yes, this makes the patients really in danger to die. And actually what we found that also the pressure inside the cell. So if you have a necrosis, you have a cyst, you have a constantly elevated amylase lipase level. So you have a problem with the outflow of the pancreas and the microorganisms stay there. I think this is the key factor. And of course, every microorganism which can be dangerous can play a really, really crucial role.
Thank you. Fred?
Thank you. Fred Korlick from New Haven. And I'd like to thank Dr. Habetzian and the speakers for, I think, a very, very important session. And actually, I hope that we think about doing, at least dedicating an hour to this every meeting to look back and see if we've made progress. And one of the issues that I think has come to mind as I listen to this is how we're going to make progress and where does one move from here. And there's wonderful discussions and ideas. And I think, as Dr. Simeon pointed out and others, certainly the cancer, those involved in cancer started many, many decades ago and are far ahead. And I just wondered, based on the models and what Diane has learned and Dr. Yadav, his experience with the Pancreatic Consortium, how do we move forward with this? What kind of groups need to get together? How's that going to be supported? Because it seems like these isolated discussions, will not move us forward unless there's a step after this.
Dan?
So I think one key thing is we don't appreciate is we have power in numbers and by working together that none of us have by doing this on our own. I'll just use the example in pancreas cancer, even if you just look like at the spore mechanism, all the, or Stand Up to Cancer, where, centers get funds and then they try to negotiate with a company to get a therapeutic agent, that the success rate is actually pretty low. So here it's about us all working together much more effectively and creating something that is of greater benefit to all of us than we can do by doing it alone. And it seems like a trivial point, but it's actually, I think, the key point. The same thing is for pancreatitis, right? You don't realize all the power you all have by working together. You just and leveraging that strength. So I think that's one key part of it. Going through an exercise of defining like what is the critical thing we need to tackle. How do we leverage our respective strengths? And then how do we build our team, which isn't just academia anymore, to get where we need to go? The other one thing I would say is having a nonprofit as the fabric that helps pull it together, allows you to be more nimble and effective. It takes longer to do this through an NIH-funded mechanism, although having the NIH as partners is very good. So, it's just a strategy to consider.
Yeah. And Fred, from a consortium standpoint, one of the ways that, for example, the longitudinal cohort study that we are doing proceed, the way that it will be helpful is that we'll be able to actually, over the next maybe 2 to 3 years, define in terms of what expected events that you can think about or what occur in this population of patients across the spectrum of chronic pancreatitis, which actually will give us a very good idea in terms of the longitudinal course. In terms of clinical, so this could be helpful when you're thinking about a clinical trial, say that lasts for more than a year or two, because we do not have a good handle, say if you have a group of people, what are the different events that are going to occur? And so for us to get an idea with regard to sample size and things like that. For trials that are shorter term, say 3 to 6 months, that's where, especially when it comes to patient-reported outcomes, that's where consensus of bringing together patients, patient advocates, and providers to develop a set of core outcomes that we need to study is going to be helpful. And then that can be studied, say, in a randomized clinical trial where the control arm is going to give you that information as compared to a treatment arm. So these are two different approaches that we can target shorter term studies as well as longer term studies.
Thank you, Dheeraj. Sohail.
Yes, thank you for the session. I actually had a question that was similar to Fred's. There's still one part that I wanted to ask about it, which is the role of professional societies, such as the APA. For example, today is a platform to be able to talk about the issues. It's also a chance to maybe give a report card later on about active clinical trials. But can we do more is the question. And I reflect on being a pediatrician on cystic fibrosis. There's a cystic fibrosis very active group that's meeting now or in a week or two. And it's a smaller disease group, much smaller than pancreatitis, for example. But they were able to galvanize around endpoints. I mean, FEV1, every pediatrician knows about forced expiratory volume as an endpoint because the society really rallied behind it and used it as their sort of first major endpoint. And then there are other examples in the IBD space, for example, that Aida has talked about. And so I guess the question, so it's an open question, we don't need to answer it now, but what is the role of a professional society such as the APA in getting us closer? Can it function like PanPromise? Can it rally behind endpoints and other parts of the process so that we don't, have a lower likelihood of failure in that valley of death and other areas?
We have many professional society leaders here present. So if you could comment.
So I think it is an important point that professional societies should have a bigger role to play in not only designing trials, but also getting people together. As Dan was saying, that the strength is in numbers. The only problem with professional society is they often lack financial muscle to actually support the trials and support studies. So in terms of organizing people together and designing trials, designing studies, multi-center studies, I think they have a definite role to play. The only thing is, and they can also engage with the regulatory bodies to make sure that the trials are taken forward. The only what they lack is financial resources to provide. The moment you ask somebody you would like to join the trial or study, they'll say, okay, yes, I would like to do that, but I need some support. So that's the only thing. Diana.
So as a past president of this organization and actually going to this meeting almost every year since 1992, one of the things I really liked about this organization, it actually brings basic scientists and clinicians together. Not that many organizations do that very effectively. Often one talk is a basic science and the next one is clinical. I think the APA has an opportunity as it now is growing and evolving to think about that. It is true that money is always an issue, but I'm a big believer that if you build it, they will come. So, we could challenge the APA to consider, and maybe it's just using the platform of this meeting or subsequent meetings to assemble people to try to tackle these things in an organized, systematic way. Obviously, the APA has the ability to bring regulatory people, not only in the US, but in Europe and other parts of the country together and leverage it for good. I was laughing because Ada's looking at me, but I'm looking at her. She's the president of the APA, and You know, this is something that the incoming leadership can think about. Can we leverage this organization to a greater level than it has been to tackle some of these really tough problems? The pancreas is tough. That's why people have not wanted to work on it. But as you always say, with challenge comes opportunity.
I think it's a very important point, but we must remember that societies can only accelerate and not start the issue. So we still need the drivers for the car, actually, who has the burning desire to deliver something. When I was the secretary of EPC, this is what I found. We were so happy to support the ideas coming in and distribute as a network, as a hub. But I think what definitely needs people who has the ideas and had the burning desire to deliver the study.
So Hale, you're up for presidency soon. So this is something we should discuss on the board. I think it's a question to you and to me and to the board is what is the call to action after this satellite symposium? And I think there is a lot of takeaway here. I think we have become a convener. I think the nice thing is there's an international representation here giving us all the different insights and how do we take that to the next progress. One of the things that we discussed recently is advocacy as well, and how do we really move that needle? I think I do agree with you, Diane. Resources, we do need them, but they are not the only. I think we need to create those endpoints, hypotheses, and we need to rally up. So it's a really homework for you and I and the board. Thank you for the question.
Hi there, Shaunak Majumdar from Mayo Clinic. What kind of stands out as a recurring theme is the need to define endpoints, the need to have expert consensus around endpoints. So I have an interest in biomarkers. My question's for Dr. Simeone. Precision Promise is fantastic, and congratulations to you and the large team that has got this up and running now. When we think of surrogate endpoints, and you mentioned predictive biomarkers, if you had to prioritize what those endpoints would be in the treatment journey of a patient with either early stage or even advanced stage pancreatic cancer, what are those endpoints that you would want a predictive biomarker to answer? And are those endpoints, do they need to be static or should they be dynamic?
So first of all, even though I was up here presenting it, this is the work of 300-400 people, and actually to a credit to our field for the ability to work together. With regards to what biomarkers you should measure, so there's pre and on treatment biopsies, and that tissue is being collected and centralized. There's repeated blood samples that are being stored that can be used for a variety of biomarkers, and there's standardized imaging. So for every arm that comes in, putative biomarkers can be proposed, and they can be validated. And we have a biomarker working group that puts that forth. And if you just, for example, take lessons learned from I-SPY 2, which is breast cancer, where that's not a registration-ready trial, but it's for patients who have locally advanced breast cancer that will go to surgery. There, they overall going to surgery and complete pathologic response was the endpoint, but they have now validated imaging findings as a accurate surrogate of surgical response. So you have to hear what we're saying is OS has to be the gold standard, but using that and measuring whatever your surrogate is in parallel. And maybe we can come up with a short-term biomarker where we could say, okay, we know if we treat somebody for 2 months, this is or isn't going to work, but we always have to validate against and this is what the FDA would expect for any biomarker. So you just want to set yourself up for success. That's kind of the key point, is whatever you build, set yourself up for success that you can truly validate whatever your surrogate is going to be.
Thank you, Diane. And Peter, did you want to add anything on the endpoints?
So, yeah, no, I would echo everything that Diane said. That the biomarker collection should be standard in all early phase trials, and we have a number of lessons from pancreas cancer where maybe 7 or 8 years ago, we didn't know how to use the information. And we started, PanCan actually started a program called Know Your Tumor, where they were funding sequencing for patients. And that really told us about the value of next generation sequencing. And we now do that routinely in the clinic. And I think these are the kind of initiatives, that was the first phase of biomarker discovery, we could say. And we were able to define some subgroups like tumors that have homologous repair deficiency. And now we're trying to expand that. And in fact, now we know that DNA next generation sequencing is not enough. We had recent data looking at RAS wild type pancreas cancers that we have to do RNA fusion testing to look for NRG fusions, for example. So we have a foundation, and we're just trying to build on it by whenever we have a new platform, we're incorporating ctDNA into most of our prospective trials now. So we started off sort of very rudimentary. There are a million publications about CA19-9 as a biomarker. And then we moved into DNA next generation sequencing. And as we know more about fusion testing, we're doing that, ctDNA. And what Diane said is that we have the platform now that we can add on all these components to it as we, if in Precision Promise, for example, we have all these specimens. So if we come up with some idea, we can go back and look at it retrospectively, and that's how we will learn, right? So we have to bank all these specimens on this study and on all our studies. I think it is imperative that we keep collecting those samples. And we in some of the cooperative group studies now, we are banking stool specimens to look at microbiome composition. So all these things are being incorporated into our prospective trials, and eventually we'll be able to learn from these things.
Thank you, Peter.
I was just going to say, if you look at other cancers, we now have multiple subtypes, and that is really important for how we treat people. And we are so far behind in pancreas cancer, and it's not our fault. It's because it's really hard to get tissue on patients. We all know that. So we actually had a lot of pushback to mandate biopsies, repeat biopsies in this platform, but really felt that we weren't going to move forward without doing that. So I do think this will be the beginning now where we can actually start to subtype pancreas cancer more effectively. And of course, critical work by Eileen and Kim and Talia in the HRD space is a start, but I think we're just getting going.
Thank you. So we are just up. We'll take one last question. That will be our final question. Thank you.
Thank you. I'm Stu Weisberg from Columbia, New York. Thank you for the session. I just had a quick question about the role of prevention. I briefly looked at Dr. Heggie's easy app model for how to predict who's going to have a severe course of pancreatitis. What about interventions that might actually prevent the progression of exocrine disease risk factors into acute pancreatitis and severe organ damage? In the same way that we don't like to wait for someone to have a heart attack, we try to give medications to actually prevent that heart attack.
Peter, that question for you in terms of prevention, perhaps in recurrent acute pancreatitis.
Yeah, I think this is crucially important because we know plenty of factors which actually play a crucial role in the initiation of pancreatitis. So even there are some of them which depend on the patients, of course, the smoking, alcohol, and so on, and the others, what we can do about if there is a hyperlipidemia-induced pancreatitis or bile-induced pancreatitis. We have to closely follow the patients, and we have to stop the initiators of the recidive pancreatitis. Otherwise, this will go around. We recently looked at actually about the activities of doctors, how they try to find the etiology factors in the idiopathic acute pancreatitis, and the results were terrible. So when the patients come and the patients are treated, we plenty of times let them go home without a proper workup for the etiological or risk factors, actually what can induce the pancreatitis or what can make more severe the pancreatitis.
Thank you, Peter. Maybe Diraj from Proceed. I know Inspire also in pediatrics, perhaps in recurrent acute pancreatitis, how we might predict and prevent recurrent attacks.
Yeah, so I was unclear in terms of whether your question related to primary prevention or secondary prevention. The primary prevention is in the population, and secondary prevention would be if somebody already had an attack of acute pancreatitis, how do you decrease the risk of subsequent recurrences? Primary prevention, I don't think that the field is there in terms of primary prevention, just because even although acute pancreatitis is common at a population level, it's actually still an uncommon disease, and the number needed to treat is just going to be astronomical. But for secondary prevention, as Peter mentioned, identifying the etiology and addressing the etiology at this time is the best way that we can reduce the risk of recurrences. In patients who have idiopathic or genetic diseases, like the Inspire study, the Proceed study, they'll give us information in terms of what is the expected risk and the events that are occurring in a population over a given period of time, then to address that.
Thank you. At this point, I will conclude. Thank you for all your attention and also for the questions that you brought forward. I want to thank my co-chair, Eileen O'Reilly, and also our esteemed panelists and speakers. If we could give them a applause, and there's going to be a break.